Assalamualaikum warahmatullahi wabarakatuh. Hello and welcome back. I'm Vila Hasanawi. I'm a graduate student of Regional and Urban Planning Program Study of Institut Teknologi Bandung, Indonesia. This is the video about discussion about Indonesia health financing system, and also I will give a solution and any suggestion and conclusion of health funding system. First of all, I will give you an introduction about Indonesia condition nowadays. So Indonesia is in the midst of the series of transition ranging from demographic to social, economy, and political. After decades out of authoritarian and centralized government, Indonesia introduced reforms in 1988 to establish stable democratic government with significant developing of authority to provincial and district level government. Strong economic growth is leading the country toward middle income status. Indonesia faced the challenge of increasing health expenditure at a national level by more than 200% over the last 8 years. However, the proportion of health spending to GDP remains below average among the low to middle income countries, accounted for 2.8% of GDP in 2014 according to the WHO database, or 3.6% based on the 2014 NHA Indonesia country reports. So after that, I will give you financial flows and health system in Indonesia. The central government financing for health come from national taxes, natural resources, as well as grants and loans from external donors that are included in the state budget. The Ministry of Finance manage the state budgets, which is then distributed to the Ministry of Health and other ministries. There are three main funding channels for funds for health expenditure from the Ministry of Funding. So, first is direct funding via the Ministry of Health. So the MOF provide direct budget transfer to central level ministry, included MHO. The MHO then provides direct budget transfer to centrally managed hospital class A and the central MHO agencies such as National Institute for Health Research and Development and the National Health Manpower Agency, and etc. So, moreover, the MHO channels fund vertically provincial health office PHO through two mechanisms. The first is the delegation of authority in form of dekonsentrasi, dekonfund, and the second one is co-administration in form of tugas perbantuan TP fund, as well as to district or city health office, or I could say is as DHO, through the co-administration mechanism. So, through the delegation of authority mechanism, the provincial health organization provide management and technical support for the implementation of programs at the district level. So, the funds channeled through the co-administration mechanism. After that, the general budgetary transfer from central government to provincial district government. The provincial district government can allocate the local budget (APBD) to health sector. The APBD budget receive funds from local resource revenue (pendapatan asli daerah) or PAD, finance balance transfer from national level to subnational government (dana perimbangan), and the regional grants and loans, and all of which are governed by the Law Number 33 of 2004, Undang-Undang Nomor 33 Tahun 2004. So the local source revenue comes from local taxes, levies, and the revenue guaranteed by the local resource management. Hasil pengelolaan kekayaan daerah yang dipisahkan. And the other legitimate revenue resource. So, fiscal balance fund derived from the state budget is transferred to the provincial government to support the decentralization system. Types of funds intended for fiscal balance purpose included revenue sharing funds, dana bagi hasil (DBH), general allocation funds, dana alokasi umum (DAU), and special allocation funds, dana alokasi khusus or DAK. So the local budget for health is managed by the PHO, and fund activities in range of healthcare provider such as health centers, hospital, and pharmacies. Yeah, the local government budget are also used for funding the local health insurance schemes, jaminan jasa kesehatan daerah, Jamkesda, that have been established in many provinces and districts to the complement of the Jamkesmas scheme, prior to the establishment of the national system, Jamkesnas. So the local government Jamkesda schemes typically cover up the health care, that mostly curative care, provided the primary care facilities and province or district level general hospital for people who have not been covered by the Jamkesmas. Okay, so we continue our discussion. So the third one is health insurance fund. Since 2014, Indonesia has started the implementation of Law Number 40 of 2004 on the National Social Security System, which mandates the introduction of universal health insurance schemes. So implementation started by merging the public insurance schemes that already exist, like ASKES, Jamsostek, and Jamkesmas. In 2040, small businesses and population groups that previously had not had health insurance could enroll the National Social Health Insurance schemes by the paying premium to the National Health Insurance Agency, Badan Penyelenggara Jaminan Sosial Kesehatan, BPJS Kesehatan. However, until early 2040, many districts and provinces continue to provide organized autonomous local schemes or Jaminan Kesehatan Daerah (Jamkesda). After that, we will discuss more about the public financing schemes. About health, of course. So, first of all, we have to discuss more about the coverage of the program, the coverage of the which people are covered by the program, of course. So, who is the covered? Since the start of the operation of BPJS Health in January 2040, the government has identified an achievement of universal health care as the main goal of its new health sector plan. As the achievement of universal health care as the main goal of its new health sector plan, as stated in the roadmap towards national health insurance for 2012 until 2019, all Indonesia citizens will be progressively included as registered member of BPJS Health by January 2019. So BPJS Health is responsible for implementation a nationwide health insurance program of all Indonesia, offering one single benefit package. So, as described earlier, the implementation will be in the several phases in line with the plan for memberships expansion, including expansion for foreigners working in Indonesia, of course, at least 6 months in Indonesia. After that, members could enroll in the national health insurance. Schemes are divided into contribution beneficiary, penerima bantuan iuran. I also call it as PBI, and non-contribution beneficiary, non-PBI. So PBI comprise poor people, yes, you may know as a contractarian principle in public goods and services, to determine in accordance with the government regulation number 101 of 2013. And besides, the non-PBI membership comprise the salary workers, the non-salary workers, and the non-employees and the family member. But they have to pay the premium to the BPJS Kesehatan also. So after the people who is covered, we will discuss about which services are covered. So the benefit package of the Jamkesnas was introduced in the MHO regulation before. In the implementation guidelines for the National Health Coverage Program until January 2017, so it has been revised 3 times, and this document stipulated that JKN over comprehensive basic benefit package provided based on a medical indication covering outpatient and inpatient care at the primary level up to tertiary hospital level, with exclusion to a few types of care that are particularly covered and fully uncovered. Yeah. So after that, it's just for basic needs. It's just for the basic and it should be covered by the BPJS Kesehatan. So after that, we will discuss how much is covered in terms of cost. Yeah, in the Ministry of Health Regulation number 40 of 2012 on the implementation guidelines of the Community Health Coverage Program, it is clearly stated that the policy forbids co-payment and no overselling will be applied under BPJS Kesehatan in relation to treatment in accordance with protocol guidelines. So, yeah, government investment in health has increased since the economic downturn in 1998, with the increasing priority to create a social safety nets in the form of social health insurance program for the poor, culminating in the establishment of the Universal Social Health Insurance Schemes or Jaminan Kesehatan Nasional in 2014. The challenge for the government is to expand this schema to achieve universal health coverage by the 2019, while addressing regional disparity in the service quality. Then beside the accessibility, managing the resources effectively, contain costs and minimize fraud, of course, engaging the private sector and maintaining investment in health promotion and prevention program. Yeah, that's about the coverage. Then the collection of the review of the revenue. Yeah, okay. First is government budget. Government budgetary contribution to health finance are provided at each level of the government: central government, provincial government, and district government. So central government revenue is derived from the 3 sources: consumption tax, income tax, personal or corporation, of course, then the oil and gas related revenue. And then the local government revenue is made up of a transfer from the central government plans local revenue. The actual local revenue, or PAD, is the revenue earned by the local government based on the local regulation, which is in the accordance with the regulation, balance fund, and the other revenue. The balance fund, dana perimbangan, is the revenue originated from the national budget, which is further allocated to the local government to fund in its needs in the implementation of decentralization. So the balance funds aim at reducing the fiscal gap between the central government and the local government one and among local government. Okay. So we will next discuss about the social health insurance contribution. Contribution to the Jamkesnas are directly deposited into BPJS Health through multiple mechanisms. So, as the SJSNH stated that the mutual funds will come from contribution in proportion to the level of income or salary, which will be pooled to financial provision when need. This is a feature that is perceived as being more sustainable as the compulsory contribution is expected to eventually reduce that state expenditure, while at the same time being cheaper over time as more members join the system national social security system. So yeah, after all, about the pooling of fund allocation from collecting agency to pooling agency. So pooling occurs through two mechanisms: pooling of central government funds, then transferring pooled fund to provincial and district government, and pooling of social insurance funds through the BPJS. Yeah, pooling and allocation from the central, provincial, and district government. Allocation of fund from whole of central government central level is determined by the state revenue and expenditure budget APBN. So the APBN allocation to health is determined by Bappenas in consulting with the Ministry of Fund and the Ministry of Health, of course, and approved by the National Parliament DPR I mean. While the Health Law number 36 of 2009 mandates a minimum allocation of 5% of the total state budget to health. This has not yet been achieved, although it's proposed for 2016 budget. Yeah. The budget allocation is traditionally undertaken on the basis first as historical budget, then proposal of the ministries, and the third one is the calculation of local needs according to the population number. Yeah, so non-technical consideration may affect the planning process. Many believe that the political aspect retains a large influence since the House of Representatives DPR plays a considerable role in determining indicative budget level. So yeah, political is also give a more effect to this part. After that, the MHO allocate the health budget among the central level department and the health agencies, and also allocate funding for the health through earth market allocation mechanism to the local or provincial and district government. This includes. So the concentration fund dan ada konsentrasi. After that, the assisting tax fund. Tugas perbantuan comes from the state budget executed by the local government and include all revenue and expenditure needs to carry out the assisting tax. The third one is special allocation fund dan alokasi khusus is located directly to the local government and earth making for special health infrastructure construction such as puskesmas, sub-puskesmas, and district hospital. Yeah. The provincial and district health agency prepare plans and budget proposal, which are largely based on the same factor as the central level. So historical allocation, request proposal from the bottom up, planning process and response to identify local priorities of determine the political party in power. Yeah. So the APBN budget allocation to health is divided into indirect expenditure, biaya tidak langsung, for the salaries of the civil servants, then the direct expenditure, biaya langsung for the operation of health service and program and allowance of staff in the provision of service. Then yeah, the the amount of the BTL is determined by the number of salary of civil servant as must be allocated to cover this requirement. Yeah. After that, we will discuss more about allocation of pooled funds for social health insurance. According to the law number 40 of 2004 and the law of number 24 of 2011, BPJS Kesehatan has to manage a single trust fund, Dana Amanat, which is pooled from the contribution of premiums of a whole population, including government funds. Yeah. With this single trust fund, the healthcare costs for all sick people are taken from a single source without having to pay attention to the amount of the contribution of salary of each JKN membership. So, yeah. The allocation of revenue from central government to the BPJS is based on the number of the member entitled to have their contribution paid by government and the agreed premium to be paid by the government. Yeah. So, purchasing and purchaser, we have to know about the provider relation in health system in Indonesia. So, relation between public provider and purchases central and also the local government, where the provider is a budgetary unit of the relevant level of government. The relationship is hierarchical and there is a direct accountability. Provision of funds is based on the agreed budget, which cannot be changed, and funds received have to be accounted according to the financial regulation and can be audited by the national or regional audit agencies. So issues here arise with the frequent late disbursement of funds from government to provider, which result in shortage of funding in the early part of the financial year and overload activities to expand all the budgeting. We pause. Sorry. It's a little bit tiring. Okay. So we will continue and go back. Next we have to discussion about the contracting relation between BPJS Kesehatan and health provider. As a single institution managing pooled funds, BPJS Kesehatan has the responsibility to pay health care costs to the provider, and as the single payers, BPJS Kesehatan has a good bargaining position towards healthcare provider in relation to such costs, and this position can be used as one way to control the behavior of healthcare provider and healthcare costs. This is the good one, I think. After that, BPJS Kesehatan should coordinate with the local health office regarding this arrangement or contract when the government or local government health facilities are eligible to compulsory cooperate with the BPJS Kesehatan. Besides, private health facilities are qualified to cooperate with the BPJS Kesehatan, but the design of such cooperation is written agreement between the health facilities and BPJS Kesehatan, of course. And the quality of BPJS Kesehatan facilities are managed by the MHO law. The presidential decree also regulates the negotiation and contract of health facilities. So yeah, cooperation agreement have validity period of at least 1 year and can be extended according to the mutual agreement. After that, we will discuss about out-of-pocket payment or OP payment, where the largest source of financing in Indonesia health system. So comprising about 46.9 of the large of health payment In the years of 2014, so OOP payment accounted for the highest proportion of payment among private financing schemes. In general, the main area of expenditure for OOP payment was paying for personal curative healthcare, including pharmaceutical about 69.6%, and in Indonesia, the average level of household spending on healthcare in 2005 was approximately 3.5 of its outcome. So, problem of disparity also still exists in terms of OOP payment based on the wealth difference and analysis of the proportion of the average monthly per capita household costs for health. Data from the Indonesia Family Life Survey shows that for quintile 5, yeah. In other words, OOP is the higher in the area where people have access to healthcare. Financial protection through social health insurance can be provided, but access among poor and rural population remains an issue, of course. Then such finding also suggests that there is an equity issue in the context of social health insurance, where poor population and those living in the remote areas will benefit less due to their limited geographical access to the healthcare. And also important to note that Susena's data do not include costs incurred for transportation, they mean that the findings and OP can be assumed to be understated. Yeah. So we also discuss about cost sharing or user charge. So the cost sharing in relation to health insurance refer to provision of health insurance or third-party payment that still requires the cost of health care received to be partially borne by the person coverage. Sorry for the word. So the prior to the introduction of the Jamkesnas, public provided at Puskesmas and the hospital level levies user charge. The registration fees at the Puskesmas level are very small. As also for accommodation in public ward in public hospital. However, additional charges were levied for two classes. First class, VIP ward accommodation. Under that, the cost sharing is not allowed. However, additional payment may be required for non-medical benefits such as higher level of hospital accommodation. For example, participation who wants to higher class of hospital accommodation can take out additional voluntary health insurance. Yeah. Then we know about direct payments are made for goods or services that are not covered by any form of the third-party payment. Direct payment account for the highest share among OOP payment. They are largely from pharmaceutical, as noted in the section on OOP. Either self-purchase or for pharmaceutical or Jigan agree list or where stock is not available. So informal payments. So yeah, beside direct payment is also indirect payment. Indirect payment is, despite not being permitted within Indonesia health system, the informal payment do exist, although the amount is hard to estimate. Yeah. They can be in various forms, including payments to health provider made by outpatient to cut short waiting lists, or that ones made by inpatient in order to receive early service such as hospital beds or room. The other form includes direct payment by the patient to health provider for certain drug devices that are not provided by the facilities, where the work not only patient pharmaceutical. So it also sometimes make informal payment to doctor as credit for having prescribed to the patient, of course. So after that we will have a big discussion about payment mechanism. Paying for health service like public health services. So public health services are funded through several of sources like central budget. So the Ministry of Health provides funds to puskesmas like for drugs, vaccine, support for basic services, and prioritized programs such as immunization, tuberculosis, malaria, HIV, AIDS, maternal care, CDC program. Then the local government budget. Local government budget provide funds for drug service through the DHO services from Jamkesda, salary for civil servant, of course. The third is funds from donor or external partner. So primary care provide of primary care services is most provinces are puskesmas under particular scheme such as health insurance from civil servants, ASKES, and compulsory health insurance for corporation, jam sostek, as well as some private insurance schemes, private clinics, or family. So BPJS Kesehatan under JKN scheme, BPJS Kesehatan paid the contract primary care provided by capitation for outpatient service. JKN member must register with the puskesmas, primary care clinic, or local GP family doctor within 3 months of becoming a member. And then if they are dissatisfied with their GP or family doctor, they are permitted to re-register with another. So in addition, primary care provided receive payment from government budget, out-pocket payment OP, then the third party insurance company. Yeah, besides we will discuss also about the hospital care. Hospital care is also receive a payment from the National Health Insurance BPJS Kesehatan. BPJS Kesehatan pays hospital for service provided to its member using prospective payment system based on Indonesia cash mix based group. Healthcare costs based on the INA CBG varies according to the regional and hospital class. So top-up payment are available only in special cases and using a cost to charge ratio. So the INA CBG payment system aims to encourage more patient focus, efficiency, and quality service, as well as to avoid overtreatment, undertreatment, moral hazard, and adverse event. Yeah. So public and private hospital might also receive payment through the following mechanism, such as Jamkesda, local government free care schemes, mainly for the poor people where available. So local government usually pay through fee for service. Some are managed by the ASKES and paid using negotiated fee schedules, and few Jamkesda can use DRG payments. So the second one is third party payment, ASKES, Demsostek, private insurance company maybe, and the direct payment from the patient using fee for service. The tariff is set by the government, central government, if the hospital are owned by the central government, or local government, of course. Then the public hospital owned by the central government receive funds from the central government. Okay, so I will make a suggestion on conclusion in the same time. So for me, this is primarily the result of a low government contribution to health financing, with the public share only 37% of total health expenditure, whereas private, primarily OOP payment, contribute 62% higher. So higher OOP expenditure has resulted in an increasing risk of catastrophic health expenditure for households. However, since 2004, the government budget for health has increased significantly. So this health budget increase was the result of the shift in government health financing policy to focus more on reducing financial risks of healthcare spending, particularly for the poor people. So this budget increase is also mandated by the Law on Health, Undang-Undang Kesehatan, which stipulates that the government budget allocation nationally should be at least 5% of the total central government budget or APBN, while for local budget APBD, the allocation to the health should be at least 10%. So based on that legal requirement, the government will increase the budget allocation for health care nationally to 5% of total government budget by 2017, and a sum which is estimated to be 109 trillion rupiah. However, government investment in health system has been limited, leading to insufficient facilities and workforce needed for public services and encouraging the growth of private health facilities. So problem of maternal and child health, nutrition, and the communicable disease persist, while non-communicable and chronic diseases are emerging as new priorities. There are significant regional disparities in terms of health status and inequality, availability, and capacity of health services. So yeah, decentralization has affected the capacity of the central Ministry of Health to maintain integration and alignment across the different levels of the health system. So yeah, following the amalgamation of a number of existing funding schemes, a national health insurance program, Jaminan Kesehatan Nasional, or commenced in January 2014, which with contribution from a member, and the government put under single health insurance implementation agency, BPJS Kesehatan. So the introduction of the JKN has been primarily responsible for ongoing increase in government expenditure since 2014. So the progressive expansion of the coverage is planned with the aim of a universal health coverage by 2019 with a comprehensive benefit package and minimal user fees or co-payment. So payment to primary care provider are through competition, and to hospital provider through DGR episode or service payment. Salaries from public staff continue to be covered through budgetary allocation. However, the budget allocation from the JKN is mostly used for curative care service and health infrastructure, so that support medical care. The allocation for public health and prevention remains relatively low compared with the higher allocation for curative service. Yeah, so that's all. I know that I've speak a lot about the public finance in health system in Indonesia. So yeah, if you want to know more about my material that I have been telling you, you could download the material in the description box below, so I will give you the link. Then you could share to your friends, to your institution that needs to know more about the Indonesia health system, health financing system, of course. So yeah, thank you very much. Thank you for having me. Of course, if you like this video, please give a big thumbs up. And if you want to discuss more about the topic, you could give a question, comment, or suggestion in comment section below. So, see you and have a good day. Bye-bye. Assalamualaikum warahmatullahi wabarakatuh.